And with that, it is my absolute pleasure to turn it over to my colleague, Dr. Domoto-Reilly, who has graciously agreed to tackle a very large topic and difficult topic, dealing with difficult behaviors. So I will stop my share. And thank you, Kimmy, again for doing this.
Good afternoon, everybody, and thank you to the facilitators for inviting me to talk about this challenging topic. I also hope that when we get to the discussion, we probably will have lots to learn from all of you. Unfortunately, this aspect of dementia is incredibly challenging for everyone, all through the disease course, and is often why people come into the clinic in the first place. So as I think we are all painfully aware, there is a high prevalence and cost of behavioral symptoms in dementia. Almost all people who carry a diagnosis of dementia will exhibit at least one behavioral symptom over the course of the disease. There was a study following people in the community over 5 years in Cache County, and 97% of them experienced at least one neuropsychiatric symptom. There are high consequences, high costs to these behavioral symptoms. There's increased utilization of services, be that healthcare services or other services. So when we think about the direct care costs, there's just the visits to the clinic, visits to the hospital, the transportation to get there, the cost of medication potentially. And I refer you to Trang's amazing talk last week or 2 weeks ago regarding medication choices. Then there's the paid care, consideration of respite stays, and nursing home placement. Then there are the heavy indirect care costs as well. Lost income for family members, potentially the replacement cost for hiring additional help around the home, somebody to keep up the house, to do the bookkeeping, to fix things around the house when that can no longer be accomplished by the person with dementia. And if these symptoms are not addressed, there can be accelerated functional decline. And there is additional fallout, not just for the person with dementia, but for their care partners and other family members. There is a wide range of potential behavioral changes. So that is part of the challenge too, is that these symptoms can just be a change from how the person was behaving before, and may or may not be bothersome to themselves or to others. So there can be the repetitive questions that come along with memory loss. There can be difficulty falling asleep, difficulty staying asleep, shadowing someone else around the house, wanting to be near somebody else, feelings of sadness, loss of empathy, a decreased motivation, delusional thoughts, being resistant to assistance, and also restlessness. This is by no means a comprehensive list, but just some examples, again, of that wide range of both activities and behaviors that can interfere with other people or not. And even just the words that we use. So when we think about someone being characterized as having agitation, it could mean that they may be hitting other people, pacing around, screaming, or it could be quieter. There could be muttering, staring, grinding teeth, tapping feet. And so when we're screening for these symptoms, we really have to think about how are we getting this information? Who are we gathering it from? And how are we going about getting it? Is it with questionnaires? Is it through conversation? Is it through calls to the clinic? There's really no universal standard. The tools that are available, there are a lot of them. They can be multi-domain. They can be specific to, for example, agitation or depression. And I refer you to Dr. Rhodes' talk from January of this year in terms of some other scales. But in the literature, the scale that's most frequently cited is the NPIQ, the Neuropsychiatric Inventory, the short questionnaire, which goes through 12 symptom domains. And there are severity ratings of mild, moderate, or severe. And this can be self-administered. But if you just hand somebody this paperwork, I think we have to be very careful with that. In our clinic, we've gotten feedback that especially the first time coming into a clinic to receive a questionnaire saying what is going wrong can be pretty discouraging. There can be a lot of differences in how the person who is experiencing dementia and their caregivers, how they characterize the symptoms, if they're aware of whether these are symptoms of dementia or not, and whether they think there is distress associated with it or not. And I point you to Dr. Ramirez's talk from December 2021, thinking about cultural differences in, for example, saying that something might be a burden or not. And that distress, even that goes along with thinking about the possibility of these symptoms, can also complicate the history taking. Sometimes it can be helpful to talk with the person with dementia and their caregiver to sort of clear the air. But sometimes it can be really difficult to talk about concerns with the person who's exhibiting the behaviors, because then that might heighten anxiety, for example. Sometimes it can help to get a little message sent through the chart or just called in before a clinic visit. So perhaps the clinician is aware of what to screen for. But I think, as we are all very aware, just observing somebody in the clinic is often not the best way to get a sense of whether these symptoms are present. And when we think about different types of dementia, and again, this is very broad, but when part of what can help with making the differential diagnosis of dementia types is what might we be looking for, what might we expect. So somebody who has dementia due to Alzheimer's disease, in the early stages, even sort of leading up the prodromal symptoms, there may be a lot of depression and anxiety in mild cognitive impairment and early stage dementia due to Alzheimer's disease. In vascular cognitive impairment, there can be depression. With Lewy body disease, I think we're all aware that there are often early hallucinations, even delusional thoughts. And because of that fluctuating level of engagement, there can be this retained insight. And so depression, I found that depression can be a major issue as the disease goes on. With FTD, there can be repetitive sayings, repetitive motor activities, a lack of empathy, which can be quite painful for the family, and also loss of social graces. And it's important also to keep in mind that these behaviors often change as the disease progresses. And so perhaps it can be helpful to hear this may not always be an issue, but also to remember to adjust treatment accordingly. And the patient insight can be variable into either the behaviors they're exhibiting, also into the cause of these behaviors, what's driving them. And sometimes that insight, as I mentioned with Lewy body disease, that may contribute to the distress. And sometimes families will say that they are thankful that the insight is not there so that they can carry some of the burden of the grief, for example, of the disease. So when we think about non-pharmacologic interventions, there's been a lot of reviews and trying to figure out, well, are they efficacious? And I think overall, it's pretty hard for us to gauge whether a specific intervention has good efficacy, because there's so much variability. Was the person in the community? Was their care partner their spouse or a child? How was it exactly carried out? There's so much variability that sort of sorting through what might be right for the person sitting in front of you gets to be pretty difficult. However, there are some general agreements in that those interventions which involve the caregiver may end up being the most beneficial, and especially it will be beneficial for the dyad, so the person with dementia and the person who is spending the most time caring for them. As with all treatment approaches, we really want to individualize to the person's particular interests and needs and skills, and also to where they are in the disease stage. And a lot of the studies are looking at, well, how are the effects 3 months out, 6 months out, a year out? But I guess I wanted to make sure that we reflect on in the moment benefit can also be helpful. Having a 20-minute period where a grandchild and grandmother can have an enjoyable experience. Perhaps it doesn't overall decrease the agitation that's being observed, but even in the moment to have, even for the grandchild to have that memorable, pleasurable experience can be beneficial long-term in ways that we don't have good tools to measure. Also, it's important to remember that while people say, we want to have non-pharmacologic interventions because there's no side effects, there can be some side effects to look out for. Sometimes, especially if there are stimulating ways of engaging with someone, there can be an increase in agitation. And then there are also those incremental costs of the time it takes to find the right intervention, to employ it correctly, and potentially the cost of the particular intervention. And part of also what's important to remember is that sort of completely disengaging pharmacologic and non-pharmacologic approaches is likely not helpful to anyone. They can be helpful to each other, and one approach could be that you would want to minimize the pharmacologic intervention as much as possible, but there can be times when both help together. So these are just some types of non-pharmacologic interventions. Again, a lot of variability in terms of whether there are actual randomized controlled trials which show benefit, but just to give you a sense of options that are there. So thinking about sensory stimulation, there's acupressure, aromatherapy, massage therapy, light therapy. There can be sensory gardens, horticulture therapy, music, dance, perhaps both together. White noise could help with getting to sleep. And then you see a picture here of the Snoozelen multisensory stimulation therapy rooms, where theoretically all 5 senses are engaged when you enter these rooms. In terms of person-centered activities, we can think about cognitive stimulation and engagement, also reminiscence therapy, so thinking about pleasurable times in the person's past, simulated presence therapy, so having recordings from a person that in the family that they're very close with, or friends, and sort of videos or audio recordings to listen to. Exercise therapy, and then also animal-assisted therapy, which could be live animals, toys, or robotics. You might be interested to know that there was a study where a robotic cat increased the pleasure and interest, but there was no change in agitation, whereas a soft toy cat really helped to decrease agitation. So again, a lot of variability in trying to sort through the efficaciousness of each intervention. But it's so important really to take a step back and look at the history and present situation in terms of each factor which influences the manifestation of these behaviors. So we are starting with a vulnerable brain, a brain that is experiencing degenerative changes or has had some sort of vascular insult, for example. And just those changes to the brain tissue and the brain chemical composition can, on their own, cause these behavioral and psychological symptoms of dementia. However, influencing this day to day are sort of 3 major categories to consider. So one is patient factors. So what was this person's premorbid personality, and are there changes or further enhanced aspects of their personality that are emerging now? Are there concurrent medical issues? And this could be as simple or perhaps not so simple as constipation. Are there different medication interactions, side effects of medications? Is this person sort of struggling with their sense of autonomy, feeling vulnerable? What is their level of engagement in meaningful daily activities? Do they feel that they are still contributing to the household in a meaningful way? And also, are basic needs being addressed? Bowel movements, urination, pain, temperature, sleep, thirst, hunger, socialization. So of course, this is quite a wide range from very mild stage dementia all the way to end stage, but important to readdress each time, reconsider each time. For the caregiver, if this person is, for example, a family member, considering that relationship history, has there always been a contentious relationship? Taking that into consideration and knowing that things are changed now can be very helpful. Does this person have a good understanding of dementia and its effects on the brain? Do they have a good appreciation of the person's current abilities? How are their skills at detecting and then interpreting the symptoms, these behavioral symptoms? What type of communication strategies are they using? And are they thinking about the person's safety and the welfare of others around them? How much is that also going on in the background? And then we can think about environmental factors. So is the person being overstimulated or understimulated? Is there a good daily routine? Is there a structure to the day? Are there tasks that they have to do or tasks that are going on around them day to day? How are those transitions between activities? Is there appropriate cueing that there's time to move on to the next one? And what exactly are they interacting with every day? What are the objects that they're seeing? How is the furniture set up? Can they get up and down from a chair easily? What is the layout of the room? How easy is it to find the bathroom in the middle of the night? What type of social interaction is going on? And then also, what are the cultural values and expectations? Was this person supposed to be the head of the household, running everything? These are all very complicated factors to be considering in terms of putting a person's behavioral changes in perspective. So there's an approach developed by Dr. Kales and her team to detect and then address, to treat these behavioral symptoms. And I'll also refer you to Dr. Carlson's great talk from May 2021 in terms of this sort of framework as well. So the DICE framework is first to describe. So this is our information gathering, the history gathering. So really collect a thorough and accurate description of what the symptoms are and what the context of the display of those symptoms was. And try to get a sense of what is distressing and to whom. Is the person exhibiting these behaviors bothered? Are the people around them bothered? Is anyone in danger? Then investigating. So evaluate both the causes of these behaviors and the consequences in order to identify modifiable factors. So again, these are the patient factors, caregiver factors, and environmental factors. Were there recent medication changes? Is there something else going on medically? Is the person's eyeglasses up to date? Do they have their eyeglasses? Do they have their hearing aids? How's their sleep been? What is the bathing and dressing routine? And what is the level of caregiver stress potentially related to or not these behavioral issues? Then create a plan, a collaborative treatment plan. Ideally, if the person with dementia can participate in creating this plan, include them as well. And it may be very helpful to either provide concrete examples of what it really means to incorporate exercise into the day-to-day routine, or to model how to adjust communication styles, for example. And then also it's important to evaluate. Once you've made recommendations, well, was that something that actually could be carried out, or was it just too complicated, or how possible was it to actually execute it, or did they try it once and just give up? If they tried it, was it helpful? Could there have been unintended consequences? So perhaps, feeding, having a meal was always pretty contentious. And so now things are great, but it now takes an hour to have a bowl of cereal instead of the rushed 5 minutes. So again, what are the trade-offs there? And to keep coming back to, are these behaviors still occurring? Are there modifications that we should think about as time goes on? And finally, I think we are all aware, but really this education and support can bolster the Care Alliance. So coming up with strategies to mitigate these behaviors, ideally to prevent them, So really think about establishing these brain healthy habits early. And that education part, a lot of times people say, well, what can I expect? In some ways, you could consider it part of education, like providing education about the risk of delirium. Although with the stigma and fear surrounding the diagnosis of dementia, I think there should be some caution in terms of not saying, here's a worst case scenario, because as we know, there's different paths for each person. And not only do we not want to make people extremely fearful about the progression of the disease, we also don't want every single little issue being escalated to a major concern. Just like also we don't need to hear every time there is a little memory lapse, making sure that we put things in context and provide patients and caregivers with a good understanding of which symptoms can be due to the dementia and which should really be brought to attention. So for example, some people may not be aware that either the loss of empathy or increasing apathy can be part of the dementia, and that there can be interventions to instill. Early identification of these changes, intervening early to reduce escalation can be very helpful. And establishing appropriate expectations. So is a behavior truly problematic? So somebody who used to be dressed to the nines every day now wants to wear the same shirt Monday through Friday. That is a change, and perhaps as part of preserving that person's dignity, the family wants to encourage them to change their clothes every day. But if it's not a major sanitary concern, perhaps there can be focus adjusted elsewhere. Also, diffusing, sometimes family members can have the perception that they're doing this just to get at me. Really trying to diffuse that perception that there's intentional antagonism going on. I've had some family members say, well, and people with dementia say, oh, I could, that's Louie today, giving a different label. That this is not me. This is the effects of the disease causing these issues. And even incremental improvements can be crucial. So just making, a little bit of the dressing and bathing routine a little bit easier can be a huge relief. So we don't need to make dramatic changes. Even focusing on those incremental improvements can be extremely helpful. Providing support to both the person with dementia and their caregivers can be very, very important. Acknowledging potential guilt, feelings of grief, and also emphasizing the importance of medical and mental self-care and respite if possible. I point you to the great talks from Fleur and Dr. Rhodes from June last year and last month also, in terms of how can speech pathologists, occupational therapists, psychologists, therapists, social workers, how can the team help provide individualized interventions? How can they provide that framework? So thank you so much, and looking forward to hearing everyone's thoughts on this important topic.
Outstanding. Thank you so much, Kimmy. That was a wonderful overview of a difficult topic. And I really love the attention to, diving into, is this something that was tried once? How long do you stick with it? What are the costs of that and the potential challenges of that? And that's such an individual and difficult question to answer sometimes. So we've got plenty of time. I would love for people to feel free to unmute and ask questions, comments, things that work for you.
I have something, a question. Could you go a little deeper into light therapy? Kind of what kind of light therapy? How is that working? And yeah, thank you.
Well, that's the difficulty. So that's one of the areas where there has been so much variation that it is very hard to, I think, make recommendations. But certainly here in the Pacific Northwest, when we think about days getting shorter, even just making sure that day-night schedule is kept and a good routine is really important. Also being sure to lower those lights at the end of the day to signal it's going to be time to go to sleep. But yeah, unfortunately, that's an area where there's been a lot of variability in terms of the intensity of the light, how often to do it. I guess one thing I wanted to mention too, which I touched on a little bit, was sometimes as part of the education is, we have these questionnaires and we say agitation and, impulsivity, sometimes providing the, hearing someone's description of what is happening and then providing a label, for better or worse, kind of like providing a diagnosis, like, oh, that sounds like impulsivity. Sometimes that can help a caregiver say, oh, they didn't mean to do that, and also to seek out sort of appropriate treatment and support for it. Hi, Carrie.
Thanks so much. I missed the beginning part, sorry. Do you have any comments on the term sundowning? I don't know whether you spoke to it. It's really common, and I've noticed my residents are starting to use it more like in the hospital, and I was like, okay, wait a second. We've got, just because I think it can be, can almost minimize it because you're just like, oh, she's just sundowning. But what part of this is delirium and what part of this is behavioral symptoms? And then also, like, I don't know whether you said in the beginning, do you have a favorite term for this, for behavioral symptoms, generally speaking? Because I've heard some like schools of thought on, what's the best language to use when we are describing this very real thing.
Yeah, sundowning, I find, I probably, as with all terms, so even helping people think of what terms to use, I think you're right to be cautious, say, well, actually tell me what is happening. And sure, that's helpful to know the time of day, but it can be, I think sometimes caregivers, want to be helpful, and they've done a lot of great reading, even saying, oh, aphasia, my aphasia is acting. Like, now, wait a minute, what are we really talking about here? So I think taking the time to get that full description of what is happening when can hopefully avoid the overuse of a label. And and then in terms of general terminology, there's been lots of different things in the literature, and then even some of the papers I'm looking at say, even if you then introduce a new label to destigmatize, overuse of then that term, brings its own stigma. So I think we do have to be careful about the words that we use and how we sort of color the emotional response to it. And I think part of it too is so a person is experiencing changes to how they used to behave, and that may or may not be a bad thing. And who is it a bad thing for and why?
Can Allison chiming in for just a second? So one of the things that I work with people who provide care in long-term care communities, and some of the things that they have shared around the sundowning, that is, there's two things that I have found helpful. One is that around that time of day, really looking at what would this person have been doing if they were a healthy person at this time of day. So if this is when they would have been leaving work, or this is when they would have been transitioning to some other activity, to then think about what could we do that would sort of replicate that in their lives. Another is just sort of coping ahead. If we know that this typically happens at this time at 4:45, what do we do at 4:30 so that this person is otherwise occupied? And then a third thing is, in long-term care communities, being conscious of what else is going around at that time of day. So for instance, if that's when there's a staff transition and the staff is putting on their coats and leaving through the front door, that can cause the residents to think about, well, wait a minute, what am I supposed to be doing? Am I supposed to be leaving? And so being really conscientious about what happens at that time of day that could potentially be a trigger.
whenever I'm teaching about sundowning, I will always mention that really like almost all symptoms get worse at night. So people who have chronic pain have worse chronic pain at night. People who are suffering from bronchitis will often have exacerbations of their bronchitis symptoms at night. I mean, it's just, there's something about like the darkness and the tiredness that makes everything worse. And so I think it's useful to frame it in that way. And I do think that it's a useful term, just like it's a useful term for when all of those symptoms and all those other conditions worsen at night, to think about sort of planning for it and how to make sort of, evening and nighttime specific interventions to alleviate symptoms in the evening at night better.
Good. I want to point out in the chat, there are a couple of resources if you haven't noticed these. Thank you, Carrie, for posting the Jerry Powell podcast. And then Carolyn, do you want to mention a little bit the resource that you discovered?
Yeah, I recently stumbled into this, and I was telling that our clinic, I can't really believe that I've missed this for several years, but Rush University's Alzheimer's Disease Center has a downloadable book or booklet. It's online. I put the link in the chat. I also put the document itself if you just want to download it. But it's, what I like about it is they're true activities rather than just something, like here's a puzzle, here's something like that. It's, Kimmy was talking about whether it's gardens or therapies that are more, and I'll use the word therapy very broadly, but interventions that get people active and specifically working together in some sort of like collaborative or mutually enjoyable activity. So it's really cool, and it's downloadable, it's free, and it lives on that website. So you can either reference them to that website, or there's the PDF there too. So it's a good find. I was excited.
Excellent. Other questions, comments before we move to the case study? I don't see any hands up.
I would just add, just like from the primary care perspective, I mean, like the vast majority of primary care clinics don't even have a social worker, and so I think the real kind of like practical, how do you put all of those non-pharmacologic approaches into practice is just incredibly challenging. And it's so outside the scope of primary care, and that, we so sorely need like a place that's easy to refer somebody to get interventions like this sort of in place. And they're complicated, and there's such an art to it, and you want it to be somebody who's like really experienced in doing it. And I know that there's like lots of places and people who are trying to provide it, but I just want to make the point that there is still like an unbelievably unmet need on a healthcare system sort of wide sort of scope, that we are like so far from meeting what we need for this.
Yeah, absolutely. And I'm realizing that Karen Clay, our fantastic social worker, is not here today, nor is Lynn Cordy. But I will, point you to the efforts of the Dementia Action Collaborative, the Alzheimer's Association, and our area agencies on aging, or community living connections, that offer a variety of different care partner trainings and some of this work. But boy, getting people connected with that and making sure that these things are evidence-based and consistent, and then consistently offered as funding will change. But certainly, I will point you to your CLCs in the communities where you are practicing. Some of that is available there, but yeah, we have a long way to go. All right. Okay. Take one last look at the chat here, and perfect. Okay, so I will then turn it over to Dr. Dodson, who has agreed to present a case today. Thank you so much. And a healthy aging nurse practitioner for the Center of Healthy Aging, at Swedish Neurosciences Institute. I believe predominantly up in Edmond still, or have you made the move to First Hill?
Not until May 1st. So
All right, still in Edmonds.
yeah.
Representing Edmonds for the time being. All right, I will turn it over to you. Thank you again for presenting the case today.
And Allison, just popping in for a second, just checking in. Randy, are you loading the slides or would you like me to do that?
I can do that if you would like.
Yeah.
Okay, hello everyone. My name is Emma Dotson and I'm a nurse practitioner at the Swedish Center for Healthy Aging. And today I will be presenting a case on cerebral amyloid angiopathy or CAA and Alzheimer's. And I'm fairly new to my practice, but I've been seeing a lot of patients with CAA, and I've realized there are a lot of implications for both primary care and teaching points for patients and families that are very important. So I thought I would bring this case forward to kind of discuss those risk factors. So learning objectives for today's case will be identifying potential mental clouding medications, both prescribed and over-the-counter, correlating imaging findings with exam and diagnosis, and then what CAA is and the implications for the patient, family, and primary care, and also teaching points for the patient and their family. So a couple weeks ago, I saw a 74-year-old female. She has a past medical history of depression with anxiety, hyperlipidemia, hypertension, symptomatic varicose veins, eczema, psoriasis, and then a new diagnosis of ADD in which she was prescribed Adderall for. Her social history is she has a master's degree in library science. She worked as a librarian and a teacher. She lives with her husband, who has multiple medical problems, and then a mother-in-law who lives with them who also has dementia, but she's supposed to be moving out to get more care in the near future. And then she has good support from her daughter who brought her in today. And then she has a son in the armed forces. He just returned from Ukraine prior to the recent events, but this is a very distressing topic for her, and she continuously perseverates on this throughout our visit. Per her daughter, she has rapid forgetting. She is forgetting where she lives, repeating herself in conversation, is unable to drive anymore, difficulty with household tasks, can no longer manage her finances, and really marked increased anxiety recently, although has had longstanding anxiety since young adulthood. And then no behavioral disturbances, visual hallucinations, delusions, no fall issues or mobility concerns, no past history of head injury. Her hearing and vision is good, and no family history of dementia. So this is her medication list. So she's got this newly prescribed Adderall, B12, fluoxetine, lisinopril, lovastatin, and then the creams for her skin, and then ZQuil over the counter for sleep. So I was wondering if anyone already had any thoughts about her medication list and potentially clouding medications for her cognition.
That's a great question, and I'm sure some of our hub team will have some questions, but is there anybody from our community that has either some thoughts or questions first?
Well, I would have some concerns about the Adderall and perhaps the fluoxetine as well. Might be causing some difficulty, and I'm a social worker, not a pharmacist, but that leaps off the page.
Okay, and anybody have any other ideas in addition to that?
Janine here from Providence. The ZQuil is definitely a little concerning with the Benadryl component.
Yeah. Yeah, so I also recognize the ZQuil. So it has Benadryl in it, which of course is anticholinergic, contraindicated for people with memory concerns. And then I did have a little bit of a concern about the Adderall just because it was a new diagnosis of ADD in a 74-year-old with prominent anxiety features, and it didn't really seem to be helping. So I did have a little bit of a concern about that one. And she's been on the fluoxetine for years, I think, for anxiety. It doesn't seem to be particularly well managed currently. So that was something we are actively working on. We want to go to the next slide. She is pretty physically active. She sees a trainer once per week. She has a pretty poor diet, which she admits to, no tobacco, alcohol use. She has trouble initiating sleep, some RBD behaviors. She actually had a sleep study scheduled and she canceled it, which the daughter didn't know about. So that's something we're going to try to pursue. And then these are her labs, her most recent labs. So pretty good. Her triglycerides were a little high. I was not sure if she was fasting during that lab draw, but her B, D were both good, thyroid good, and everything else within normal limits. So for her exam findings, her motor and neurophysical exam was within normal limits. Her MoCA was actually better than I suspected it would be. It was 25 out of 30. Her deficits were primarily in delayed recall with no improvement in cueing, and then she didn't know the exact date. But during the exam, she really had rapid forgetting, repeated herself, continuously asked the same questions. She perseverated a lot on her son going to Ukraine, and the daughter had to continually remind her he's back from Ukraine. And she kind of just had a lot of anxiety surrounding that, tearful at times, and she followed multi-step commands well. So this is her MRI. So she has some temporal horn enlargement here, suggesting some atrophy in the temporal lobe. If you want to go to the next. And then this is her MRI on the SWAN or GRE image. So the susceptibility weighted image or the gradient echo. And so this is important for looking for CAA because it shows blood product disposition. So the hemosiderin staining right here, you can see in this left lobe, she has a lot of these little microhemorrhages. And if you want to go to the next. And then I circled all of them for everyone. So she has quite a few diffuse microhemorrhages. This is the impression of her brain MRI. So it's concerning for CAA. And then her hippocampal volumes were low. They didn't do an actual volumetric analysis, but so she has some signs of AD, both in exam and the brain MRI, and then the CAA was very concerning. So what is CAA? So CAA is amyloid beta depositions within the small to medium blood vessels in the brain. And it basically causes these small little microbleeds from vascular rupture in the subcortical white matter. And it's an important cause of lobar intracerebral hemorrhage in older adults. And it's common in conjunction with Alzheimer's disease and can cause more severe cognitive impairment for people who have both of these comorbid conditions. So my plan for this patient, I just wanted to finish up the treatable dementia workup with the syphilis and HIV labs. I did recommend she try to discontinue the Adderall if she can, because it just didn't seem to be helping. And she was very hyperactive during the exam. And I was a little bit worried that maybe this was just anxiety. And then of course I suggested stopping the Z-Quil, doing the sleep medicine consult for the RBD behaviors. We added trazodone for sleep. We're going to continue the fluoxetine for now. I wanted her to try to do some psychotherapy, some non-pharm measures for anxiety, especially given the recent events with her son. And then we started donepezil. We'll titrate to 10 for memory. And then we'll do neuropsych testing with our neuropsychologist and see her at a memory wellness visit, which is where she gets the neuropsych testing. And then we follow up together and talk about the results. And we did a lot of teaching on advanced directives, legal planning, dementia care roadmap, and then of course the therapeutic lifestyle interventions for dementia prevention and slowing progression, including the MIND diet, increasing her personal training sessions, more help in the home, a DCC referral, the dementia care coordinator referral for her daughter, and then cognitive and social stimulation, managing her stress well, and then meditation and mindfulness practices. So for the CAA, I try to do a lot of teaching on just mentioning that there is a risk of having a hemorrhage. So it's really important to minimize those risk factors. So avoiding aspirin, ibuprofen, warfarin, DOACs, and then even over the counter, such as ginkgo, vitamin E. So these are some important things for primary care to note, just to make sure the patient's not taking any of these. And then also that patients with CAA can have increased cognitive problems, especially if they have comorbid Alzheimer's disease. And then they can have these decreased level of alertness spells. So that's something to make sure you're aware of as well. And that is it for the case. Does anybody have any? Anybody have any questions on that one?
Really nice, interesting information, interesting case. You know, we still like, it's not up there, the cerebral amyloid angiopathy and, you know, the differential as I think it should be. What is the natural course, if you could remind us, and how is it different than Alzheimer's disease and vascular cognitive impairment and dementia? Yeah,
so if somebody has CAA, they're going to likely continue to have these little microhemorrhages. And then some patients, it'll progress into having a large intracranial hemorrhage. So that's something that we need to be aware of, and just making sure they're avoiding these blood thinners, falls, whatever we can do to minimize their risk of having a large hemorrhage. And then it comes with cognitive impairment, of course, like a vascular cognitive impairment. And then if somebody also has comorbid AD, they might have even worse cognitive impairment. So it's just something to keep in mind of that's a cause of part of their cognitive concerns. And for this patient, her presentation was really consistent with AD, but I mean, as time goes on, she might continue to have more hemorrhaging, and that might cause even increased level of cognitive decline for her.
Any other questions specifically about this patient or this case? Oh, I see, Deborah, you've put a very good question in the chat. Are you able to unmute and ask that? Expand it.
Yeah, I just wondered about folks who have AFib and are on some type of anti-coag regime, how to describe to family and the patient the risk benefit of continuing on versus stopping.
Yeah, I mean, I would definitely want to talk to their cardiologist about that first and just see, just talk about the risk benefit analysis and doing maybe a Has blood score, and just thinking about that. And then also, I mean, maybe they would be a candidate for the Watchman procedure or something like that and get off anticoagulants. But that's a really tough problem to have. And there is actually some good information on UpToDate that goes through the steps of determining if the risk is worth the benefit in a case with somebody with atrial fibrillation and a bleeding disorder or the CAA. But yeah, that's a really tough situation. I think I would definitely want to consult with cardiology before I would talk to the patient and family about that.
I would put in the plug that lots of patients with AFib on anticoagulations don't have a cardiologist, and it's the primary care doctor who is who's making that decision. And if I were their primary care doctor, I would stop their anticoagulation. I would be very worried about making things worse.
And I would think too that this is where blood pressure control is so important. You think about the risk for bleeding is because of the blood vessel walls are they're just not as elastic. So it seems like this is where the stroke folks really pay attention to blood pressure.
Yeah, and just to put in another plug for primary care, I mean, so because I would bet you that many cardiologists would say, I don't know, because like I can tell you what the risk is to their heart, but I'm not their brain. I'm not taking care of their brain. And so they would probably, many cardiologists would probably defer to a neurologist or a primary care doctor on that question. And I would say that, the role of primary care is to look at the whole person and to, to weigh their brain and to weigh their heart and to make a call in a situation like this, that the risks of anticoagulation in a situation like this, I think, would relatively clearly outweigh the benefit.
Emma, I have a question. I don't get an MRI in a senior person that doesn't show chronic microvascular disease in the interpretation by radiology. How does this differ from that?
I'm sorry, can you just clarify your question? Sorry.
Well, every MRI I get in a senior, the radiologist comments on chronic small vessel disease and microvascular disease, and does that have is there a crossover in that with this? Because I've never seen anybody report the particular findings that you've described.
Yeah, so usually the radiologist or whoever read the MRI will say the pattern of these microhemorrhages is consistent with maybe a cerebral amyloid angiopathy or whatever else. So we'll see that usually in the report, but I always go through the MRI myself and look at either the GRE or the SWAN imaging and just make sure there's not any microhemorrhages that are visible on those two pieces of the MRI. But usually the radiologist will recognize that on the report. I mean, is that your experience, Dr. Eisenberg?
Yeah, I was just going to add, and thank you for that question, Jeff. I mean, I think what you're referring to is when you're reading the report, they're looking at this microvascular ischemic disease, which is very different from these microhemorrhages that we're talking about in this context, where you see in a different sequence, either gradient echo imaging or SWAN, this blood product or hemosiderin. That's not what we're talking about. That's different from the microvascular ischemic changes that are those paraventricular white matter changes that you see commonly on the T2 flare that can sometimes look along the ventricles. So that's a very different finding. It's also related to vascular disease, but a different process, an ischemic process, not a hemorrhagic process, not a microhemorrhagic process. And yes, I think I'll also echo in terms of the blood pressure control, we want to be really aggressive. And then Emma, did you want to talk about the lipid control?
Oh yeah, Dr. Eisenberg and I found a article last night that was talking about how if the LDL was less than 70, you're actually more at risk for having a hemorrhage, which I thought was interesting. And this patient, her LDL was in the 90s, but we want to make sure it's controlled to prevent ischemic stroke, of course, especially with vascular risk factors, but having an LDL that's lower than 70 actually increases the patient's risk of having a hemorrhage, which I thought was very interesting and good to note. Are we going to send out that article, Dr. Eisenberg? Yeah.
Yeah, we can. I think so, with the emails. And then the other thing that I'll add with these patients with cerebral amyloid angiopathy is that it can be confusing. They can have these amyloid spells that are thought to be associated with the small microhemorrhage that can at times look like a little seizure. And of course, people with cortical dementias can also have seizures. So if somebody had these transient neurological symptoms, you would also think of a stroke, needless to say, but you may consider getting an EEG. And if the EEG just shows diffuse slowing, it's likely that an amyloid spell.
I guess one other thought about the MRI findings is you do need, as Emma was mentioning, to have those specific sequences. You won't see these microhemorrhages on a flare sequence. So that is one little catch. I think more and more it's becoming standard to include a sequence that detects microhemorrhages, not all the time. Also, there can be microhemorrhages, for example, after a traumatic brain injury because of shearing. And there can be also calcifications. It just shows up in the same sort of black dot way. So again, relying sometimes on the radiologist's expertise there and the clinical history.
And as you pointed out so nicely, Emma, the distribution of the microhemorrhages is in the cortical regions, is suggestive of cerebral amyloid angiopathy. You can see little microhemorrhages in basal ganglia, thalamus, in hypertension, but that's not the appearance that you demonstrated.
I'm curious too, Emma or anyone else, how you talk to patients about CAA.
Yeah, I usually pull up the MRI and I show them the little microhemorrhages, and I just talk about how there's this condition that you have that is causing some amyloid buildup in your vessels and causing these little tiny microhemorrhages. And this patient had no symptoms of this prior other than just the memory concerns. And then I just say that you are at risk for increase in bleeding. And I talk about how we can minimize those risk factors, how we're going to continue to monitor this over time. I try not to be too negative on the aspect of this might, I say there's a risk of hemorrhage, but I don't say like, you will definitely have this very large hemorrhage and die or anything like that. But just telling them that there is a risk with this, and this is something that we need to closely monitor together.
I would just go back to sort of briefly to the lipid lowering discussion we were having before, which is that it's somewhat important to distinguish between the proven benefit of statins for treating sort of macrovascular ischemic stroke than to treating microvascular, like vascular dementia, that that there's still uncertainty about what the efficacy of statins are for treating microvascular disease and vascular dementia, and such that I think there's better data for blood pressure control than there is for lipid lowering therapy.
Emma or anyone else have a question? If this patient, or when these patients go on to have that large intracerebral hemorrhage, what is their clinical course typically like? Is it different from other types of hemorrhage?
Dr. Eisenberg, do you want to answer?
I'm sorry, what was the question, Mimi? Sorry.
If this woman or others who go on and do have that large intracerebral hemorrhage, what is their clinical course like? Is it similar to other types of hemorrhage, or is it different?
I mean, it can be fatal if they have a large lobar hemorrhage. That's the main and
so when they have the hemorrhage, it's typically a very large one.
If they're having these microhemorrhages, which we saw
right.
on the imaging, but the type of hemorrhage that we're most concerned about, which could be fatal, is a lobar hemorrhage, just a very large bleed in one of the lobes of the brain.
Thank you.
Yeah. And I'll just add, I totally agree with you, Barack, that the data around statins and vascular dementia is not so clear. However, the data regarding secondary stroke prevention is pretty compelling. So, and given the association of, cerebrovascular disease, as you said, so I think if somebody has had a stroke, as many of our patients have, and they don't have cerebral amyloid angiopathy, such as this patient, then we would consider that more aggressive treatment with a high intensity statin to an LDL of less than 70.
Yeah, but it's also worth, like, the pathophysiology of a large ischemic stroke and the pathophysiology of microvascular changes leading to dementia is probably a different pathophysiology. And so I guess I would just caution about sort of extrapolating the secondary prevention of a large ischemic stroke to the treatment of microvascular disease leading to dementia is maybe
absolutely. Yeah.
Points. And Trang, I see you've got a hand up. I'm wondering if you're going to ask about the the fact that she's on B12, but her B12 is only 329 still, maybe that's not your question. One of my questions, I'm just gonna throw it out there.
I was gonna say, great case, and I love the plan. I think that stopping Zyquil is very appropriate because it's Benadryl, and then also the Adderall because she has issue with sleeping because Adderall is a stimulant, so it would worsen the sleeping issues and also can worsen anxiety. So she already has those issues. So I think stopping Adderall is appropriate. I also look at drug duplication. She's on clobetasol solution and betamethasone solution. Do you know why she's on both?
I don't. I mean, she has a psoriasis and the eczema history, but I don't know much about her dermatologic regimen or anything.
Yeah, usually I look at that. So maybe maybe she can get by with one instead of both. And then I asked you to answer Dr. Rhodes' question, the vitamin B12 less than 400. I actually looked this up, and I know that there was a discussion about vitamin B12 under 400 in the elderly that is considered low B12. But I looked at that recently, and I can't find any data stating that. Usually considered low is and under 250. Anybody has other findings? Because I really actually look for that to find out where the 400 number comes from.
I've been talking about this with Elizabeth, the nurse practitioner in our clinic, because how do we get this? Because we've been looking at 400. She did some sleuthing around, and part of it too is there is variability from blood draw to blood draw. So keeping that in mind, we used to say, well, let's make sure we're looking at 400. We're now looking more at 350, 300. The balance of, do you add another pill versus, there's sort of vulnerability there. But yeah, the exact cutoff is elusive, but probably worth making sure that we are checking it and then prompting questions, as I think Emma, you brought up. What is this person's diet like? What is going on here, and making sure we're not missing any sort of pernicious anemia. It is funny. I've had a couple patients who at the initial workup did B12 and folate, and then for different reasons years later, getting great care at home, their B12 levels really plummeted and so I'm not saying that we need to recheck B12 every year, but it was just surprising to me that again, there continue to be vulnerabilities, taking care of the whole person and really thinking about how the person's whole body is working for their brain health.
I guess the other thing I was curious about with that, and it's been a little while since I've looked at this literature, but the fact that she's got ongoing depression and anxiety and maybe this B12 deficit, and I know for a little while there was interest in like MTHFR mutations and what that meant around B12 risk or metabolism and antidepressant efficacy and cardiovascular risk on top of that. So I don't know if that's relevant here, but it just came to mind as thinking about her pieces of the puzzle. Got a few more minutes. Other questions, other thoughts about this case or CAA or comorbidities with CAA and AD? We can always give you 5 minutes back of your day. All right, well, maybe with that, again, thank you, Kimmy, for presenting. Thank you, Emma, for presenting. Thanks for the great discussion. And I will remind you that our next session, I'll share my screen here for 1 second, is coming up on April 22nd. And our didactic will be Dr. Gaster talking about advanced care planning. I believe we have a case that is in the works for that session as well. And you will, if you haven't already received it, you will receive the 1-minute post-session survey, and we welcome your feedback. Otherwise, have a lovely Friday afternoon. Take good care of yourselves, each other, and we'll see you in a couple of weeks.